Hi, everybody. This is Glenn Woodworth with the Society for Education in Anesthesia, and welcome again to one of the SCA webcasts on innovations in anesthesiology. And today it's my great pleasure to have Dr. James Phillip. He's an anesthesiologist at the Brigham and Women's Hospital in Boston, and he's professor of anesthesia at the Harvard Medical School. And he is the driving force, innovator, inventor of the Man Anesthesia Simulator. And this is a great project, and it's fantastic to have him on today to chat about it. So thanks a lot for joining us.
Okay. Thank you for inviting me, and I'm happy to be here. Thank you, everyone.
Awesome. All right, so we're excited to talk about this project, but let's kind of start back because this project has had a history of more than 30 years, right? So let's kind of talk back, at the very beginning what was the problem that you were trying to solve, or, what made you even get involved in this project?
Well, I was a new faculty member at the Peter Ben Brigham Hospital before it became Brigham and Women's Hospital. Leroy Van Dam was my chairman, and he came to me one day and said, "Jim, inhalation anesthesia kinetics is not very well understood by anyone. Seymour Ketty did the original work in 1950. Since then, we've had Ted Eager and John Severinghaus being the only people who really understood inhalation kinetics. I know that you were trained as an electrical engineer with bachelor's and master's degrees in that, and I knew that before I brought you here as a resident and now on the faculty. I think you should learn how to teach inhalation anesthesia kinetics so that there's someone else who understands it and so that we all can understand it. It's crucial to everything we do within our inhalation anesthetics, understanding how those drugs move around the body. And you should learn how to do it. And the way I'm going to make sure that you do is I would like you to do grand rounds on that subject in 1 month." So there I was, new faculty member, new job for grand rounds in a month. And I did all the reading I possibly could. I read all the papers I could find, and I did identify that one by Seymour Ketty, 1950, in the journal Anesthesiology, the lead article that month and that year, where Seymour Ketty said, "Here's how the drugs move from the vaporizer to the patient's brain. Here's the mathematics of it. Here is the physics of it, and I will explain it in this journal article." And in it, he had a very nice depiction of the bellows that you would use to give air into a fire, that you would pump the bellows and move air. And he used that to represent the lungs, and then connected that to a group of compartments and went through a series of experiments that went through all of inhalation kinetics, pretty much all of what we know even today. And
let me just interject a couple of quick things there. First, this is not an uncommon method for a faculty member to get involved in something. The chairs often, and now we can say this as we are elder statesmen in our subspecialty, but I find this true and also in my own career, that a chair may identify a particular area or need, and they try to match a junior faculty member to that need to help kickstart, to fill the need, but also to help kickstart the career of that junior faculty member. So I think your story is not that uncommon. Good chairs are often really good about identifying good projects that have, that will help you in career building. So I think that's definitely a mechanism for getting into this type of work. Now, your chair only gave you a month to prepare for that, but how did that experience lead to more? And I guess I'll back up by saying, I think in my own experience, I still think that anesthesia residents sometimes don't get the deep training about inhalational anesthetics and their kinetics. It's one of the principal things that we do, and it's something principally, we use it every day. So if anything, it's one of the things that we should understand the most about. Just like we need to be experts in propofol, we should be experts in the inhalational anesthetics. And so sometimes I feel like, maybe there's a little bit of a gap still that exists today. So tell us a little bit about, so after your grand rounds, you thought that you could do more. So how did that lead you to developing the simulator?
Let me bring you to that grand rounds. So the grand rounds approach that I used was I built a hydraulic model with liquids in plastic containers. There was a Buratrol that was the wider one, and there were the other devices all connected together with tubing and roller clamps and stopcocks. And what I did was I reproduced the original Ketty article by having the liquid flow from compartment to compartment. And what I did was I took an overhead projector and laid it on its back, pointed up at the screen so that it would project the model of things growing. And that let me demonstrate how the drug moved from vaporizer to brain. So once I had done that, I felt very proud. I felt good that I had done it, and the overwhelming response I got from residents and faculty was, this was really cool. I, for the first time, understand the movement of these substances and how it all works. I felt really good until I spilled the blue water all over my white shirt. And I said to myself, I think I can't give this lecture again ever. I think what I need to do is find a better solution to this problem. And that's when I decided computer software was the right way to do it, and that I should write a computer program to do it. Now, each of us, whatever we do in medicine, ought to be picking things from our prior experience and how to bring that into medicine. And I was fortunate that I had been an electrical engineer. So that was my prior experience. But each of us can do that in whatever we do, taking what we've learned before. So I went and decided that I needed some resources. And I actually got a grant from the Apple Educational Foundation in order to have the Apple II computers available to me to be able to program to do this. I enlisted a resident and a graduate student to help work on this project. And unfortunately, they had a hard time getting it done in ways that were going to be very useful. So I, as a new faculty member, said, I think I better take this in my own hands to do what of it I can myself to make sure that I get the job done. Sometimes we have to do that in the faculty. We don't want to depend upon our residents, and our residents don't want to be depended upon to do things that a faculty can do. So I ended up actually writing there over the next period of time. And I
I'll
knew
have to
that,
say, as a counterpoint to that, that on the other hand, sometimes for the right project, a resident can be an excellent resource, but they're pretty busy. So it's a lot of times fairly difficult for them to contribute significantly to a project if because of their time constraints. Sometimes, on the other hand, actually a medical student that might have dedicated research time sometimes actually can be a better resource. And of course, a graduate student that has funding or something like that, of course, can be a great source as well. But I think that's the reason why sometimes medical students find it. Residents find it a little bit challenging to participate on projects that have quite a bit of a time requirement. Now, I know we could go through 30 years of history, and that would be tough in this short period of time here. Tell us a little bit about what the product looks like today.
so the product today is a computer software that one downloads from the internet for free. The student edition of Gasman is totally free. And once we download it, then we install it on a Mac or Windows computer. It doesn't run on iPods, but it does run on real computers. And then one can go through the workbook and do a set of experiments that teach the entire course in inhalation kinetics. The course is set up in such a way that one goes from experiment to experiment. And the workbook allows one to just flip the page that says, here's what's the next thing to do. And those pages are all in PDF files. They can be printed if one wants, but otherwise one can go through those exercises. And if
Let's
you and if you don't want to go through the exercises, you can download that set of exercises and just play them back on your own computer without running them yourself.
Okay. How long would it take a student to go through the entire workbook?
If they go through the entire workbook to learn it all, it's about 4.5 hours, or at
Okay.
least so it resulted when we actually studied a group of students that I'm sure you're going to ask me about in a little while.
All right. Can you maybe share your screen and just show us, one example of what the Gasman simulator looks like and one
Sure.
experiment?
So here's the gas man screen. And let me, for a moment, put the graph back over here, and I'll take that out in a minute. So what we have is a picture of the schematic representation of a vaporizer connected to a breathing circuit, connected to the patient's lungs or alveoli, going then to the arterial blood, to the vessel-rich group, muscle, and fat, and then coming back in venous blood to the patient's lungs.
Okay.
Now, the vessel-rich group contains the brain, which we really care about, and the heart, which we don't want to depress too much. But the goal of anesthesia is to get the anesthetic level up to the dotted line and keep it at the dotted line. The dotted line is placed at 1 Mach for whichever agent we have chosen to do the simulation of.
Okay.
I'm going to grab the graph and move it over here. And then what I'm going to do is I'm simply going to click the run button and let's see what happens. Now I've paused things when we've had the vaporizer was set to 3.6%. That, by the way, is the magic number for sevoflurane. That's
Uh-huh.
the inspired concentration that will get the expired concentration up to 1 Mach based upon the blood gas solubility of sevoflurane. But we
Okay.
don't learn that until the next chapter in the book. But that's why it was set there to make it easy to get the anesthetic to the right level. Meanwhile, because I grabbed the tab of the graph off here, we've seen the inspired came up, the alveolar came up, and the vessel-rich group in red over here has not gotten anywhere near that dotted line. Now, we're only looking at the first 5 minutes, so we better expand that out to a longer period of time. And we'll let this be a 15-minute graph. And I'll click the run button again. Now, I paused it on purpose when the alveolar partial pressure or concentration has gotten up to 1 Mach.
Mm-hmm.
Notice that the vessel-rich group isn't really there yet. And if we look at the simultaneous graph of this, we can see that it hasn't reached there. So we're now, the clock over here says we are in 6 minutes and 28 seconds of simulation. We have delivered 6 milliliters of sevoflurane liquid, and the
Mm-hmm.
patient's body has taken up 0.92 milliliters of anesthetic. So we're always looking at what we are doing and what the patient is doing. We can
Okay.
look at ratio of those two as efficiency or the difference as the waste. But now it's time for us to say, Dr. Phillip, we've looked at the anesthesia monitor and it says that the end tidal concentration is 1 Mach. And the brain says, I'm not awake. I'm not asleep yet, rather. The anesthetic level in the brain still is a couple of minutes, probably about 3 minutes from there. So the brain will get there 3 minutes later. And those of us who think that we can track just our end tidal monitor are missing that part of the story. And
So
that's in a different chapter later on.
So if I were to kind of summarize part of this is a simulator where you can vary all different kinds of variables. So let's say I could manipulate the inspired sevoflurane concentration, and I could see how long it would take for the vessel-rich group in the brain to reach 1 Mach. That would be an example of being able to manipulate variables just to see what would happen. But the workbook is specifically designed to change variables in a certain way to illustrate one principle or two principles at a time. Is that kind of the way it works?
Exactly, yes.
Okay. So what would be the first couple of modules, just as an illustration, what kinds of things would they manipulate and what would be the points you would be trying to develop in the first few chapters?
Well, in the first one, let me just close this as I speak. I'm going to discard that simulation. I'm going to do a new simulation, and I'm going to do this not with a semi-closed circuit. So now we're looking at the control panel. In the control panel, I'm going to have this be an open circuit or a non-rebreathing circuit. And then I'm going to look at what happens if I had the vaporizer to the top and I had a patient who had no cardiac output. Now, this is an imaginary patient, but we can do imaginary patients here.
This patient wouldn't be doing very good.
Nope. But what we want to see is that the initial rise of the alveolar partial pressure of anesthetic is an exponential curve. And that exponential curve has a time constant equal to the volume of the patient's lungs divided by the ventilation into the lungs.
Right.
We now
So you're
know
explaining the washout, the wash in essentially just to the lungs with no effect on uptake from the cardiovascular system.
exactly.
Okay,
So
so you
now,
might run a simulation like this, and then the subsequent simulation might illustrate another point. And as you worked your way through, you'd eventually become an expert in inhalational anesthetic kinetics.
exactly. And in fact, we'll superimpose the graphs of each of these on the initial one, and that superposition will then draw all of the same graphs that Seymour Cady had in that original article.
Hmm.
It,
Let me
I
let's ask
took
a
him as the
question about
great
how.
teacher,
Sorry.
and I took him as the great teacher, and those of us doing the experiments being able to do what that great teacher did.
Let me ask you a little bit of practical implementation in programs. Obviously, this sounds like it'd be great, and it'd be much better than reading about it, in a giant textbook. How did you find practically programs would do this? Would somebody like you get up and give a grand rounds and run through several simulations, or would they try to assign it to learners to do, self-guided learning? What was your experience in talking to different programs?
Well, when I have a student, I have the student go through the book. I say to the student, open page 1, look at the book, and give me a call when you have any questions. And typically a medical student, this would be, that medical student would come back a few hours later and say, I got up to chapter 4 and I've got a question. And that student would then ask that question and I would answer it and they'd go back. And at the end of a day or so of working hard for a medical student, they would often come back and say, I think I've mastered the whole subject. Now, with our own residents, what we do is we say, we're going to give you a homework assignment. The homework assignment will be give an anesthetic with isoflurane, with sevoflurane, and with desflurane. Give it for an hour and a half. And at the end of that hour and a half of holding the patient at 1 Mac, wake the patient up and look at the 3 simulations of those 3 anesthetics and see what you've learned about the time course of anesthetization first, and then the time course of wake up, and identify that the patients are different and that the timing difference is pretty much just what we see when we do these in real experiments. So that's how we've done it with residents. And in
I
fact,
guess I was thinking that you've probably been a grand round speaker at multiple different institutions, and I was just curious about what your experience was and how they're implementing in their curriculum. What was your experience with that?
usually what I've done is given grand rounds where I've taught most of the course. And then in some programs, any program that has a teacher who understands and wants to teach inhalation kinetics, they have then been able to teach that to others and get them motivated in some places to do all of the experiments. And I saw that at the University of Rochester, where when I came back there, they said, yes, we've actually been using this and doing it actively. And in many other places, they've simply learned from the original Grand Rounds talk, where I tried to cover the majority of the subject matter in the period of 45 minutes to get that covered. So it can be used either way.
Okay.
Sometimes we have residents who then say, I want to do a study on what happens with, oh, our chief resident a couple of years ago said, what happens if we get airway obstruction during an inhalation induction? And I said, I don't know, go simulate it. And she and another resident worked on it together. And the next thing I knew, they showed me the draft of the manuscript. The draft of the manuscript showed that it can be really dangerous doing things that we've taught are really safe. That is, we've always said airway at risk, use an inhalation anesthetic because you can always get it out. And the answer is you could do that with halothane. But with sevoflurane, the blood gas solubility is too low. When the patient stops breathing, it doesn't go away. And we learned something that way. So different residents in different institutions will use it in different ways. And even faculty members will sometimes use it in an incredible way. Would you like to hear one of those stories?
Well, I would, but I feel like we're going to get close to the end of our talk, and I have so many more questions to ask you. So
Okay.
maybe we can come back to that if we have a little bit of time at the end. What I wanted to talk about is, part of the purpose of these webcasts is again to help junior faculty understand, what it takes to develop a project, and this is a pretty complicated project. So let's talk a little bit about going back to. You said you had to do it all yourself. I'm sure somewhere in that you brought in a lot more resources as you probably developed some initial prototypes. Tell us about that and tell us about the resources that were required to develop a project like this.
Well, in this particular case, it was going to other individuals who understood the development process and how to get things done effectively. In this particular case, it was programming in a language which was easy to work with, so that there I didn't need to pull in that many resources. The major resource was getting the little bit of funding to get the computers needed to do it. Well, we don't need to do that anymore. We all have those computers and we can use them to solve problems.
But
I,
did you ever get grant funding from like FAIR or, the Anesthesia Patient Safety Foundation or any other sources to help support this project?
no, this was at a time that the Anesthesia Patient Safety Foundation was not even in the mind of myself and others who were early proponents of that safety era. Uh, it did not require a fair grant because it really was something that the idea here was going to be you could create the tool, or I could create the tool, and then others could use it, and they have gotten grants to study different pieces of this. We've had this done in Europe, we've had this done in India, we've had this done in China, where people have simply said, GasMan is now a tool that I can study things with and end up publishing interesting things that nobody has ever answered before
I
from
guess I
data that
guess I guess what I'm trying to get at is, let's say you had a junior faculty member that had a great idea for a simulation. Virtuals, online simulations now I think are a big deal, particularly in this time of COVID. And so, let's say they had a great idea about trying to build some sort of simulation, and it was fairly complicated. Again, what would be your advice to them about what resources would be able to, either time, money, other things, how would they bring the resources to bear to be able to develop a new simulation?
we always
Not,
start with
not
our
using Gasman, a new project.
Sure. We always start with our own department, asking our chairman for help. And often a department will provide a little bit of time and a little bit of resources. In this COVID era, we don't always have that time, so that's a lot more difficult. And we need to focus what we're doing on the areas that others are willing to spend money on. We certainly have FAIR as a possibility. FAIR's job these days is to train new, innovative people to do new things and take our specialty forward. So that's an important area that we should all recognize, and that is their job. The
Yeah,
Anesthesia Patient Safety Foundation does have grants if what you're doing is in the safety area.
mhm. Both of those organizations offer grants on the order of $100,000 to $150,000 over a 1 to 2 year time frame to try and help new faculty members do development. Usually, what's required is, as you said, your chair has to provide some seed time and funding so that you can develop some sort of pilot or proof of concept that you can then use to try and apply for the grant funding. And those grants often will come with protected time of somewhere around zero point 0.2 or zero point 0.4, or maybe even as much as 0.5. There are some that go up to 0.8, but that's kind of a different funding source. But let's say zero point 0.4 funding to give you some protected time to work on a project. So I think that's kind of a path that I might suggest to young faculty to think about, is starting with the department to get seed funding and time to develop a pilot that then can be used to support a grant application to then further develop the project. Would you have any other advice for young faculty members?
I think there's one very important piece of advice here that we don't often think of. Recognize that each of us need to spend our own time very often on getting things done if we really want to succeed. If you're happy to give anesthesia for a living and spend your time clinically all the time, that's wonderful. And it's so important to society and everyone else. But when you want to advance academically, it sometimes takes some time on your own until you bring in those funds that you want to do. And I think we really have to accept that and recognize that you don't have to sacrifice family and things that are very meaningful to you. You can bring them into your life in ways that it all works. And I think
Okay,
sometimes
that's I think that's good advice, and it also sets a little bit of an expectation that it's not uncommon. People that are really successful, like yourself, put in a lot of sweat, equity in developing whatever like this project. I'm sure took hours and hours of your time. Um, did you, I know you've published in this area, and others have actually published work using your tool. Tell us a little bit about, any educational outcome measures or anything that you used to show that implementation of this within a curriculum affected resident training in some way.
well, we took a set of our residents and came up with a pre-test and post-test that we would do on inhalation kinetics based upon what the boards require us to understand and based upon what was also taught in that original article by Seymour Ketty, in fact, the concepts there. So I created a pre-test and post-test and did that in a pair of them. When I say I and collaborators, Joseph Garfield and my own institution and Sandy Paskin at Monmouth Medical Center that had a residency program at that point. And we took our residents and their residents and gave them each the Gasman book and a program and made a computer available for them to simply learn inhalation kinetics on their own. And what we found was they took 4.2 hours, increased their knowledge, their skills, and their attitudes towards inhaled drugs significantly. And there was almost no difference between the Monmouth Medical Center and the Harvard Medical School in the advancement that they all made. They started a little bit differently and they ended a little bit differently, and their paths were almost identical. And we published that in in the Journal of Education and Medicine. Uh,
Okay.
it was a very profound article because at that point people were saying education using computers is not working. And this was one of the first successful journal articles in medical education, demonstrating that you really could educate by using a computer. And here, the significant thing was I was at one institution, Sandy Paskin was at another institution. Neither one of us interacted with our residents except when they needed help, at which point we were available.
Okay. So from an educational research project design standpoint, you have a pre and a post test as demonstration of knowledge acquisition, but also the study was multi-institutional, and that gives you some generalizability of what you were doing. And I think that's important for people that are designing education research projects to consider. I'd like to kind of wrap this up with, this is a fantastic project. I mean, I just can't even imagine, all of the work that you did to do this. And we all can take a benefit of that because what I heard was that you say that this is free. So let's go over it again. What I heard was a couple of things. First is that you recommend that you get um, a faculty member that's interested in this topic to become an expert, that they will serve as the person that will help promote and drive this teaching of inhalational kinetics in the department. But then also individuals can do individualized learning by downloading this. So what is the website? So let's just kind of confirm that.
Gasmanweb.com is the short one. That is, we're a nonprofit, so medmansimulations.org is the official name. but we had gasmanweb.com
So
first.
if I go to gasmanweb.com, I could download either a Mac or a PC or Windows version to run on my own computer. I get the workbook, and basically I could go through it. I could do that 4.5 hours of training. Is that correct?
That is correct. You've got
Okay.
it.
All right. Awesome.
Really stand on your own. If you have questions, you can write to teacher@medmansimulations.org. And at the moment, I am that teacher. And my hope is in the future, we will have other people who will be able to answer that call and do that.
Okay. Well, thank you so much for joining us today. This is an amazing project. I'm glad we were able to touch on a lot of things that would be valuable for junior faculty that are interested in developing their own projects. But I can only congratulate you on a tremendous career and really providing this amazing resource to all the anesthesia trainees out there. So thank you so much, Dr. Phillip.
Thank you, and thank you for giving me the opportunity to remind others that you can download and learn this very important subject totally on your own.
I think it's awesome. All right. Well, thank you so much for joining us on this webcast, and it was just a pleasure to have you on.
And thank you.